what we want to do today is tell you a little bit about what the Health Advocates Office is, what's our mandate, who do we serve, and how do we do that, how you could use our office, and maybe how you could encourage others to use our office, what you can teach us at the same time as we're helping you find your way through the craziness that is the health system. I've worked in the health system for, well, probably 40 years, and in 4 different provinces. So, and I don't know how it works, honestly. Really, if I'm honest with you. So I know a lot about the health system, but it keeps changing. Not only does it keep changing, but society keeps changing, so our needs keep changing. And the health system tries to respond to it, and then, so I don't know. But I can tell you that our office tries to run as fast as we can to try and keep up with it. So when I think about the average Albertan, or perhaps the average Aboriginal Albertan, trying to understand how this system works, I think, well, if I can't do it and I've been around this long, in a lot of places, why do I think everybody else can? So what we hope is that our office kind of helps you along a little bit with that, and helps to point you in the right direction for a lot of things. So we are the Health Advocates Office. We are what we like to see is about elbows length away from government. We are employed by Alberta Health, not Alberta Health Services, so the ministry. For those of you who aren't aware, Alberta Health Services is much more the operational arm of healthcare in the province. Alberta Health is generally the policy side of that. More policy-driven stuff around how health will work in our province. Except there's little pockets within the ministry of actual operational stuff, like our office. So just when you thought you had it figured out, again, we messed it up and got everybody confused. So we're employed by Alberta Health, but we have a separate office from where most of the other ministry stuff is, and a separate database that we keep independent and private from them. So we're kind of separate, but we're kind of not. And that's the reality of it. We have in our office a health advocate and a mental health patient advocate. Today it's the same person. And her name is Kathy Ness. She is appointed by government. So the health advocate is an appointment. And the health advocate and mental health patient advocate reports directly to the Minister of Health. So her role is really to look at what we deal with every day and try to advise the minister on what kinds of things we see missing in the system, where gaps are, what's not working right, what's working well, all of those kinds of things. So we kind of work on 2 different bases. We hear from you, the individual in the community who is struggling with what's happening in their healthcare world. And then we also gather that information and look at the big picture trends that we then say to the advocate, we need to share that with the minister. It's not just the minister though, because all of you know, there are lots of big power people working in healthcare in all kinds of places within the system. And those people have committees and working groups and all those kinds of things. So there are times when as an office, we get to be involved in some of those. And when we do that, we are hoping we are taking the voice of Albertans, regular Albertans, family members, patients, people who work in the healthcare system, anybody who encounters the health system. We are hoping that what we do is representing some of your voices at some of those tables and saying, this does work or this doesn't work. So that's a little bit about who we are. Where did we come from? Well, actually, the mental health patient advocate has been around for about 30 years. And it was at the time that it was being recognized within the mental health community that, you know what, people with mental health issues, serious mental health issues, need to have some of their rights protected. They really do. So if we look at 100 years ago, and if I had some serious mental health issues, or maybe even if I didn't, and my husband didn't like me too much, or my mother, or somebody, I might end up in hospital against my will for a long time, without much for rights. So across the country, you saw a big change of people recognizing there needs to be some rights for people who are significantly impaired by their mental health issues. So the Mental Health Act was created in Alberta, and the Mental Health Patient Advocate was created at the same time, and it particularly looks at those people who are under the Mental Health Act, so in a designated facility, and they're being detained, so that means not there because they're choosing to be there, right? Someone says you must stay there. It also covers those people who are under community treatment orders. So those people who there's a requirement while they're still living in the community to follow some kinds of direction laid out in that order. So that office has existed for about 30 years and has always provided rights information to those people under the Mental Health Act and their families and staff who work in the mental health system, and has always looked at when there are times that people feel their rights have not been upheld, looked at that from an investigative standpoint and said maybe we need to look at that. Then what happened about 5 years ago is we created a Health Act in the province of Alberta. And it's an aspirational document that says, you know what? There's some stuff in the system that we pretty much have a right to. You'll find that the stuff that Renee spoke to early this morning about international human rights and health issues are also in that charter. So right to access, things that are safe, participation. You'll see that there's parts in the charter that says the system has to provide this, but also you as a patient need to provide that too. And this lends to some of the stuff Deanna spoke about earlier too, in terms of what we have to do together. Together we need to let people know when things are working and when they're not, and work on those things as well. The health charter isn't something you'll read, when you read it, you notice, you'll say, wow, how do you actually enforce this? Well, we don't. What we're doing is trying to keep working towards this because it's right. So I want you to have a look at the health charter and really know that that's what we're supposed to be working towards, all of us. So this health advocate office got created, and what happened was it got physically located together with the mental health patient advocate office. Well, that makes sense because we're kind of a whole body, you know. No one recently has detached my head and my mind from the rest of my body at this point. So that makes a whole lot of sense. What we said was, though, that we can serve people better. And so we started cross-training our staff so that we could become an office where all of those things get served. The legislation, though, for the Health Act is somewhat different than the Mental Health Act. So we have a rule there where, again, like not duplicating services, if someone calls our office or inquires at our office about a concern within the health system that someone already looks at. So for example, a complaint about my doctor. I'm complaining about my doctor and my doctor does not appropriately practice medicine. Well, that should go to the College of Physicians and Surgeons, and they have a complaint process. So we're not going to duplicate that. We're going to say, this is where you need to go for that, if that's what you need to do. So it's a referral process. We kind of do a little bit more, as Deanna was saying, a bit more of the holding your hand on that as well. So this is what you can expect there. Trying to help people along so that they have an understanding of that. So we have a referral process in that way. We also look at what we would call navigation. We talked about that earlier this morning as well. So how do I get myself around all of this complication that is the health system? Because you know what, until you find a need, you don't know how that works. And you shouldn't be expected to know how that works. But all of a sudden, we find we have a diagnosis in our family, or something that goes on, and we go, oh, now we need and you don't know how to do that. So what we try to do in our office too, is to help you figure out where you need to go. And understand some expectations, because we all have some ideas in our head about how the health system does work. And it may be that way, but it may not. And so we do lots of sort of coaching and teaching and helping people to really understand how things work. We also do a lot of sort of option providing. Well, here's an idea you could look at. Well, here's another option you could look at. Have you ever thought of, so we do a lot of those kinds of things as well. And that's all in this navigational range that we do. So we have some specific things that we hope to do. We hope to follow this health charter and open up this health system to all of us so that we have a better understanding and a better handle on it for ourselves. And don't feel like we're in such a panic when it actually comes down to the health crisis that's happening. Everybody who calls our office or emails our office or walks into our office is in crisis. We know that. We know it's not a crisis line. It's not a like, it's happening right now. They wouldn't be calling if it wasn't a crisis. So one of the big things our staff does is listen. And that's really important. One thing we hear a lot is, and we spoke to this morning, we hear a lot of people saying, I never felt listened to within the health system. And I've worked in the health system for a long time, so I know there must be a few more people who did listen. But if they did, maybe they listened in a way that it didn't feel like it to you, or it didn't look like they listened, or they didn't tell you they listened, or they just didn't listen. And so sometimes you need someone to tell them, just to say something to someone, this is what I've experienced, and it really stinks. Or this part was really good, and that's okay. And lots of times it is helping you sort out what's the big issue, particularly when you talk to people who have very complex cases, and they call you and tell you, we have this and 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 this going on right now in our family. So how do I sort out what do I do next? How do I sort that out? And so we do a lot of that. Our staff is 12 when we are fully staffed. And there's a lot of people in Alberta. And everybody has health issues. Every single person. So we'd like to do more than we can, but we keep trying. And that's probably a big motto in our office. Well, we'll try. We'll try. We have no power over how the health system works. And I was just saying, we don't have a big stick. There are days when we hear a story and we say, oh, like a big stick? That would be really good. But we don't. And so what we try to do is help to build capacity as much as we can on an individual basis, or like things like today, where we can try and help people within a community, help themselves, help get forward, help get answers, and if they need some more, come back to us again, we'll help you some more. So we like to do that as well. People phone, so we have callers all day, every day. People email, people can drop in, but of course we're only in Edmonton. So that's how we serve people. We don't have enough staff that we can come and walk with you to your doctor's office and help you along the way. So what we try to do is empower you to be able to do that yourselves. So that's kind of what our office looks like. I want to tell you a little bit more about what we see happening within the system. And then I'm going to pass it to Ryan, who's going to talk a little bit more about the Mental Health Act and how the MHPA works. We're seeing some very significant things within the system in a general way. We see a very difficult situation with the patient-focused side of things, right? So it's all very well if as a patient I fit into this box, or that box, or that box. But if I have individual needs, and guess what? I do, I'm an individual, then it becomes harder, and it becomes to me like I'm feeling like I am just a cog in the wheel. And so what we hope to do through our office is try to help you sort out how you can be accepted as not just a cog. And so we often get into those kind of discussions with people about when you go to that appointment, do you take a list with you? Do you have a list of questions? Do you ask for what the other options are? Do you ask another question? And when in doubt after that, you ask another one. So that you can get the most information to advocate for yourself through the health system, anywhere in the health system. It is not perfect in any way, but neither am I. I keep trying. I think we're still trying in the health system. We owe it to ourselves to keep fighting them and say, here's ways it can improve. Here's ways that we think we can change how that is for each one of us. And so we keep working on those kinds of things.
I'm just going to talk about the Mental Health Act very briefly. I think Catherine kind of outlined the role of our office, how the health advocate and mental health advocate interplay. Most people are not familiar with the Mental Health Act. Maybe they'll apply in your life. Family member, friend, client may end up being brought to the hospital against the will or placed under community treatment order and fall under the Mental Health Act. So that's kind of a lot of the work we do in our office surrounding that type of situation. So we get calls from family members, clients, so patients in hospitals, nursing staff, doctors, all the time about how the Mental Health Act is applied, what that means in specific situations. Today what I'm going to do is mostly just give a couple examples that I think are relevant to our conversation today. So just briefly, for anyone that's not familiar with the Act, it allows for people that are suffering from a mental disorder, which can be defined very broadly, if there is a legal definition for it, to be brought to the hospital and detained there for a period of time to be assessed and treated against their will. So these are people that are in the community suffering from mental disorder. They're at risk of harm to themselves or at risk of harm to others, or in all likelihood for most people, they're at risk of deterioration, deteriorating physically or psychologically. So what that really means in real life is you're not doing well at home. Maybe you're not taking care of yourself, you're not feeding yourself, you're deteriorating in some way. And that's typically what brings most people into the hospital because their family members and friends are concerned about them. Once you're in the hospital, you have a specific set of rights. So there's actually 7 legal rights set out in the Mental Health Act. And everything else is more or less what we call, or what is often called, privilege. So if you can imagine everything that you guys have today, your headphones, your coffee cups, your cell phones, all of those things can be removed if the treatment team feel that it's necessary and required for treatment. And a lot of the people that are detained under the Mental Health Act will find themselves in that situation where they will be kept in the hospital, their personal belongings removed, and their perspective of personal rights and freedoms suspended. And so when we get a call, that's typically what it will be about. No one will let me leave. I don't understand why I'm here. They've taken my cell phone. Walkman? We don't have Walkmans anymore. That's what came up. But my personal belongings, sometimes even my very clothing, and I've been forced into hospital pajamas, and those things happen from time to time. And, there's reasons why those things occur, and we often explain those reasons, and we explain a person's rights. So when this happens, you have this option. When this happens, you have that option. And a lot of that's around appeal mechanism. So if you feel that you should not have been detained in the hospital against your will, you have an opportunity to object to that, and you can go before what's called a review panel to have your certification or admission challenged. So one of the things when you're locked up in the hospital, it can be one of the best experiences in your life. It can be life-changing. Often it is not. So we work in that area, right? We hear from people that are, where that's coming from. We hear from people that are very happy with their stay in the hospital, and they're calling us with a question. And we also hear from a lot of people that have a lot of concerns. We wouldn't be there if there weren't concerns to express and for things to be looked into. So I have a few more minutes, and I'm just going to give a few stories. I think from the top of my head, and I'm not going to change much of the details because they're probably pretty prevalent from time to time. So, and how our office has interplayed with people and the results from their interactions. So I'm just going to give an example of two First Nations ladies, two different stories, and two different time periods. So one was from quite a few years ago, and me not having an Aboriginal background was questioning why she was calling me with certain things. So she was calling me from an emergency room, locked up in what we call a seclusion room. So really where there's not much to do, being assessed for your health, they're concerned that you maybe will leave the hospital, and you don't have a lot of options. So you often don't have your cell phone, if we had cell phones back then, things like that. This individual really wanted to go for a cigarette, is the way I was interpreting it. And I very clearly said, well, it's really up to the doctor to determine if you're safe, you're able to go for a cigarette, if you're going to come back in time. The doctors and clinicians and the nurses assess those sorts of things. And the individual said, well, that's not the issue. And, well, that's always the issue. I get 10 calls a day of wanting to go for cigarettes, so this is in my head. Safe. Well, okay, what's the issue? So she said, well, you know, in my belief system, Aboriginal perspective, tobacco is very important. She explained a little bit about it, and how for her, playing with tobacco outside is part of her spiritual practice, and if she were able to go outside and do this, this would be healing, important, and really made what for her was a traumatic situation a lot better. And I was like, that's not true. So I talked to a few people, called the hospital, talked to the manager. The manager was like, that's probably not true. We eventually found the Aboriginal liaison who didn't work in that hospital but was connected. Found out, yes, it is indeed true. So found out about a lot of things, and it was a great learning for me. So by connecting the Aboriginal liaison worker to the next hospital, they were able to meet with the manager and met with the patient. The patient was able to go outside. The practice was kind of fulfilled. That changed the course of events for that young lady, and that's an important part, right? So the need was met. She felt respected. She felt that her, I'm guessing as to her feelings to some extent, but this is what she's expressed to me. And ultimately her stay was better, eventually discharged from the emergency room. And I'm going to give another story. So she called and said it was very helpful, thank you, and went about her way. I'm going to give another story that didn't have, in my opinion, a good outcome. So another individual, another young lady, more recent. This individual called saying, I'm pregnant, and I was locked in the emergency room, and the security officer, so most hospitals have security, they intervene when there's an incident where aggression is brought under control. Security officers threw me up against the wall, et cetera, hurting my baby. Well, first thing, like, why would that happen, right? So we look at things from an investigative angle. Let's investigate this concern. Looked into it, found out the lady was actually pregnant. It took a while to find that stuff out, actually. The lady was 9 months old, so instantly I'm like, if I were a security officer, why would I throw the person up against the wall? We looked up into the situation, and As much as I forgot to say, the backstory to these two people is both had schizophrenia. The first individual was a lot more stable when she came, was a good advocate, was able to call me and explain her needs and explain her problem. We were then able to connect her to the resources table. Second individual, also with diagnoses of schizophrenia. We didn't even know whether or not she was pregnant. Right? So we looked into these things because, again, this concern I heard a couple times from this individual. It just didn't make sense. Why would anyone throw someone up against the wall if they're pregnant? And so we had to look past the illness. We had to look past the unlikelihood. And it turned out that to some degree that incident did occur. There's more to the story, of course, and we'll get to the details. But this individual ultimately was thrown up against the wall when she was 9 months pregnant. Now, I'm not a doctor. I don't know whether or not that's a serious concern, but we looked into it. Now, that's not the important part of the story. The important part of the story is I lost contact with the client, with the patient. And in the attempts to investigate the concern about the patient being thrown up against the wall, we ordered medical records and did a preliminary investigation. And what I found was very concerning. The individual did have a baby. Big surprise, she was pregnant. The baby stayed at the hospital and left the hospital. And the part was the discharge summary, which was bothersome. And the discharge summary essentially said, homeless addict discharged. And none of it makes sense. It said a little bit more for confidentiality reasons. That's what I'm saying. And then I looked further into it because that's not the story I heard from the client. I looked into it. This person had fetal alcohol syndrome. This person had a very close family member that had looked after them 24/7, and that family member had called the police and the ambulance because the person was having a episode in relation to schizophrenia, not because they were pregnant, not because they're having prenatal concerns. So this person had a ton of support on the reserve that they lived on from the family and the healthcare services that were provided for them. And that was clearly written earlier in the medical records that apparently were not looked at. Maybe because it's an emergency room, maybe because it was busy, I don't know all the reasons. Unfortunately, we lost contact with the individual, but it was very clear that this person had supports and should have gone back home to these supports, but instead were discharged to the streets as a homeless, addicted, aboriginal person. And that was actually written in the chart, and that wasn't the case. So I guess that's why I'm bringing it forward today.